Now we're going to do a part that is one of the core elements of the treatment. This comes out of the Beck model, and if you were doing a more pure version of cognitive therapy than the TADS model, which is kind of a blended model, this would be your main focus, okay? So one of the criticisms of the TADS CBT was that it didn't do enough of this, okay? I don't know where, it didn't do it. It certainly didn't do as much of it as straight up cognitive therapy. And whether that would have made any difference in the outcome, I don't know. You'd have to compare the two. But we did think it was important to do this. The other criticism of the TAD CBT was it didn't do enough of the behavioral activation. So I'm sure both criticisms are true. I just don't know which one would have made a difference, if any, if either of them. We talked yesterday about, I think we talked about it in the open session. I know I talked about it with one or two participants, that there are efforts now to develop simpler methods of CBT for adolescents, including one by Elizabeth Macaulay and others at University of Washington, which is based mainly on behavioral activation. And in the adult literature, there is evidence that behavioral activation alone can give you pretty much the same outcome as combined cognitive behavior therapy. So I would say the two ideas that people have at the moment about what absolutely positively must be included in treating depressed adolescents is behavioral activation and cognitive restructuring. At least one of them has to be included if you're going to call it CBT. So when we developed the TADS approach around the turn of the century, around 2000, we included both behavioral activation and cognitive restructuring. And we left it up to the clinicians how much they wanted to emphasize one or the other. And what people generally did was they did more cognitive restructuring if the kids seemed to be benefiting from it. And those kids tended to be more verbal, maybe more reflective. They had a better capacity to think about their thoughts. I forget, it might have been Bill Pelham, one of the speakers on Wednesday talked about this, that it's hard for younger children, 7 and 8-year-old children, to think about their thoughts because they don't have the cognitive development yet to reflect as much on their own thinking as adolescents do. This is kind of the Piagetian thing, like you go through pre-operational thinking, then concrete operations, and formal operations. It's not really till you get to formal operations in early adolescence that your cognition is developed sufficiently that you can really reflect on your own thoughts or see your thoughts as one possible way of thinking about things. So anyway, that's what people think at the moment. Who knows what they'll think in 2 or 3 years? It depends what comes out of different studies. But in any event, we thought cognitive restructuring was an essential element, and we called it a required module. We wanted all the therapists to use this with all the kids during the treatment. And then it was up to them how much they wanted to use it or how much they wanted to emphasize it. Okay? So it's, this slide is maybe a little misleading. It's actually the 5th of the skills overall. You have mood monitoring, goal setting, behavioral activation, problem solving, and then cognitive restructuring. When I said it was the 3rd core skill, I was thinking of behavioral activation, problem solving, and cognitive restructuring, and the other 2 is kind of preliminary. But in any event, it's the 5th one presented in the manual. And cognitive restructuring can address different kinds of cognitions, automatic thoughts, dysfunctional attitudes, and core beliefs. And the advantage of cognitive restructuring is that once you learn how to do it, you can apply it to any kind of thought. So let's review for a minute the Beck model of cognition. I think it's helpful to remember that Beck was trained as a psychoanalyst. He talks about this all the time if you listen to him describe how he came up with his model. So he was used to the idea that some things are on the surface and some things are unconscious. And although he moved away from psychoanalytic thinking, you see some elements of it in this model. So his idea was that on the surface you have automatic thoughts. These are the things that you are immediately aware of. So if I'm driving to work and I'm in the left lane and some guy runs up in the right lane by me and pulls in front of me in the left lane, I have an automatic thought, which I won't repeat here. Okay, it's right on the surface. Okay? Now, that's a rapid on-the-surface image or comment. This reflects an underlying belief. My underlying belief is you shouldn't pass on the right. If you're in the right lane, you should not pass somebody in the left lane. That's a conditional belief. If you're in the right lane, then you shouldn't come into the left lane in front of me. And I might even have a core belief, if this really upsets me and I can't calm down all day because of it, then there's something going on here, right, that needs a little intervention. And it might be, that the world is unfair and every driver is a jerk and, you can't trust people and they break the rules and blah, 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 blah. Okay, so that would be a kind of a dysfunctional belief. Okay? But the dysfunctional beliefs are not on the surface. They're really not in conscious awareness. Okay? So here's an example that I think I mentioned in the talk Wednesday. If Mary fails a test, her automatic thought might be, I am no good at math. Her dysfunctional attitude might be, unless I excel in all areas, I am stupid. And this may reflect a core belief, I am incompetent. Okay? So the core beliefs in depression, the typical core beliefs in depression are not that many. You can kind of make hypotheses about what might be the case for your particular patient. One of the core beliefs that's common in depression is I am unlovable. Another is I am worthless. And a third is I am helpless or incompetent. Okay? And these beliefs, people carry around with them from early childhood until they get triggered by some activating event. That's Beck's theory, kind of simplified, but that's the kind of classic cognitive theory. There are two major classes of events that trigger depression: failure or loss. So in Beck's model, he talks about sociotropy and autonomy. And some people their core beliefs are very tied up with social acceptance and lovability. And so they score high on these scales called sociotropy. Okay, there are questionnaires that measure these dimensions. And autonomy is the other dimension, which is people whose their core beliefs are tied up with their achievement. Okay, so you can sort of guess when somebody comes into treatment for depression based on what triggered the depression, which might be relevant here. It could be both, but which might be relevant. So, and I find it interesting. The course I teach in the graduate school is personality assessment, and I find it interesting that the psychoanalysts have the same two things. So they call them anaclitic and introjective depression, but they're basically the same. Anaclitic depression is depression triggered by a loss, and introjective depression is a depression triggered by a failure. So there's agreement across some major theories on this. Now, what about cognitive distortions? You have probably heard of them. We're going to talk about them in a couple minutes. There are certain ways that people distort their perceptions or their thoughts that are classic in depression. We saw some of them in the role plays yesterday. So if I believe that I am incompetent unless I get an A in every single course, I may have a cognitive distortion of not paying any attention to a B plus or an A minus. That's just not acceptable, okay? That's a cognitive distortion of dismissing the positive, okay? So cognitive distortions fit into this model in that they maintain the negative core beliefs by twisting or ignoring or overemphasizing information, okay? And this forces the perception then to fit the belief. So for example, same example. Mary fails one test. There are many possible interpretations she could use for this. She could say that was a hard test. Or she could say, I'm not very good at that section of the course. Okay? Or that test was unfair. Or I did not study well for that test. But if she decides, based on failing one test, I am no good at math, she's overgeneralizing, right, from one negative event to a big category. And this serves to activate her core belief, I am incompetent. So if you get a kid referred to you for depression and it seems like the trigger was a school failure, then that sort of suggests that the core belief you're going to have to deal with has to do with competence. It doesn't prove it, it just makes you think maybe that's it, okay? So, how to discover the adolescent's depressive thoughts? Because if you're going to do cognitive restructuring, you have to know what you're trying to restructure. So, as a clinician, there are many ways that you can try to figure out what the various depressive thoughts are. And these are some of them. What precipitated the depression? If the kid comes in because, like my patient that I talked about yesterday, whose suicide attempt was precipitated by a breakup with a girlfriend, what core belief is that most likely to reflect? I'm unlovable, because it's an affectionate, affiliative, sociotropic thing, okay? It has to do with another person. So, so the guess would be that it's I am unlovable. So what precipitates the event might suggest a core belief either of helplessness, incompetence, worthlessness, or being unlovable. That's one way to look at it. A second way, which is, pretty easy if you have access to these questionnaires, some of which are, I think, in the public domain. You can give them questionnaires when they enter treatment. There's a questionnaire that Kevin Stark and Nadine Kaslow developed called the Cognitive Triad Inventory, the CTI. And it just is a list of automatic thoughts that have to do with the self, the world, and the future. There's another one called the Automatic Thoughts Questionnaire that was developed for adults. I think Steve Holland and Phil Kendall developed it. There's the Dysfunctional Attitude Scale. Okay? If you give any of these at the time of your assessment, then you already got a jump start on what might be the negative cognitions. One of the most common ways we discover what the negative cognitions are by looking at the themes that emerge during therapy sessions. So you pick up pretty quickly by listening to kids talk about what happened during the week or what they want to put on the agenda, what their themes are. Do the themes tend to reflect relationship issues? Do they tend to reflect achievement or competence issues, or both. Another way, which is very useful, especially if you have training in interpersonal or psychodynamic therapy, is to use that training to notice what kind of affective shift happens in the session. So a kid's talking about something and all of a sudden they shut down, or they change the topic, okay? Or their facial expression changes, okay? So you know, if you're trained in any of those other models, that's where the action is, okay? And it's also where the action is in CBT. The adolescent demonstrates a shift expressed non-verbally, changing focus, avoidance, discomfort, facial expression. The therapist then reflects the emotion. So you ask, you say, like, it looks like you got upset by that. What thoughts or images were going through your mind? Okay. What was going through your mind when that happened? What are your thoughts about that? I noticed your mood just seemed to shift. Can you tell me what was going through your mind? And also, what does that mean to you? So if somebody says, I felt bad because I called my friend and they didn't call me back. What does that mean to you? What does that suggest to you? They tell you that they felt particularly bad one evening since the last session. You ask them what was happening, what were you thinking about when you felt bad? Now you can see why this is easier to do with people that are more verbal and reflective and insightful. It's just easier. It's not that other people can't do it at all, but some people take to it quite readily. A thought monitor is a triple column, so it's simply a piece of paper that has on the left-hand side the days of the week, and up top it has event, thought, feeling. Okay, so those are the three columns. It is in the packet? Okay, I can't find it. What? What's it? You sure it's not the mood monitor? That's the one I used yesterday. This is it looks the same, but instead of having morning, afternoon, evening, it would just have event, thought, emotion. Okay? So you ask the person to take this during the week, take it with them during the week and fill it out each day, and to write down any event that gave them any particular emotion. Any emotion they notice. It could be a good emotion or a bad emotion, happiness, sadness. What was happening, what was the emotion, and what was the thought. Okay, so sometimes you got to spend time just with two columns. You got to spend time helping the kids see that events lead to emotions. That's what that first mood monitor is for. And then the second mood monitor, which is a triple column, puts in the thought part. Yes?
I frequently get the response, I don't know.
Right. That's true. That's right, they don't.
Probing.
Keep probing, yeah, right. So what can you do? So the comment was you frequently get the response, I don't know. Are they able to do the event and the feeling?
Usually I'm not using those kind of organized approach.
Okay. So one way to try to, there are many ways to deal with this, which is why the manual's got like everything known to man in it as ways you can try to use it. One way to try to do it is to give them two columns first, and as in that mood monitor, and just say, try to notice during the week, any time that your mood changed, what was happening when it changed. Okay, so they may come in and say, "Oh, I noticed, my mood was good when I was in the lunchroom at school. Or my mood was good when I was out with my friends on the weekend. And my mood was bad when I was home alone in the afternoon." Now you're starting to get a picture here of what's going on, even though they haven't said what's going on, but they're telling you basically that they feel better when they're in social situations, and they feel not so good when they're alone. So that's one way to get started with people who are not aware of the connections. Another way, which I don't have this on the slides, but it's in the manual, and I really like this. I like it because I made it up, so I always like the things that I make up. But this thing that I made up was to tell kids to write down some event that happened. No, here's the way it goes. I give them an event. I say, you're in an automobile accident. You were driving along the road, and somebody ran a stop sign and hit the back of your car, but nobody was hurt. Tell me at least 2 feelings you could have in that situation. Now, what are 2 feelings you could have in that situation? Fear, anger, relief, right? At least 2 of those 3. And then you say to them, okay, let's talk about the fear for a minute. What thought is connected with feeling fearful? What's a thought that was connected with feeling fearful? I could have been killed, right? That's a thought. It's a fearful thought. It makes you feel fearful. What thought is connected with anger? Yeah, a jerk ran the stop sign, right? That's a thought. That's a different thought than I could have been killed. And then what's connected with relief? Nobody was hurt, right? Nothing worse happened. Now, this is an exercise that's structured so that it forces the adolescent to identify at least 2 emotions connected with a single event. And the reason for doing that is to show that what mediates the relationship between the event and the emotion is the way you think about it. Okay? So I do like to use that. I think it's in the TADS manual, but I forgot to put it on the slides. Yeah.
And John, I'd also say, the research on using mindfulness or teaching mindfulness skills to adults and adolescents
Mm-hmm.
the research is out there now that's very helpful. And when kids say, because adults say that too, when you ask them, what were you thinking? I don't know, because they're not attending to
Mm-hmm.
themselves and their thoughts, their cognitions. And so if you take a step back, teach mindfulness skills
Mm-hmm.
first,
Right.
and then step into the cognitive restructuring, you might have more success getting them to attend to their thoughts in
Right.
the first place.
So the comment is the mindfulness training preceding cognitive restructuring can help people learn to attend to their thoughts and emotions more. Okay, and this is a newer development in CBT, newer than what we had available in 2000 when we wrote the TADS manual. And a lot of people are using it. And one of the nice things about mindfulness, I don't do mindfulness, so I don't know much about it, but some of my colleagues do. It's part of DBT, right? Part of dialectical behavior therapy. One of the really encouraging things about mindfulness training is that it seems to reduce the risk of relapse. There's a study recently out, Zintel Siegel, I think, is the author. It was in the Archives of General Psychiatry with adults, showing that mindfulness training reduced, after the person got out of the depressive episode, they were treated for depression. And then a certain number of them were randomized to receive mindfulness training. That group had lower levels of relapse than people who didn't get the mindfulness training. So it's something definitely worth looking into and perhaps incorporating in your practice if you have a chance to learn how to do it. Okay. Could you explain a little bit about what it is so that people know? Would you talk in the mic about it so we can get it on?
Well, like I said, mindfulness, I mean, it's used in Marsha Linehan's DBT therapy, but it's been around forever. Yeah. I'm not an expert in mindfulness, but I use it as part of DBT, and I tend to focus on the DBT skills in mindfulness. The skills are observe, describe, participate, one mindfully, non-judgmentally, and effectively, and they're skills that are very helpful, but particularly observing and describing, which we tend to talk about as, really just attending to yourself, paying attention to your thoughts, how normally, your average person goes through life just kind of on automatic pilot. You just do what you do, and it's very habitual, and we don't really think about what we're doing or what we're saying so much. We just do it.
Right.
Some people more than others. And so you just focus on getting them in touch with, what's going on with their mind and what's going on, and connecting that to their emotions, their feelings, and things like that. We find it really, really helpful.
So for example, would an example be that, I wake up in the morning and I'm feeling anxious about something, and being mindful would be to say I'm feeling anxious, but not saying that's a bad thing or not.
Yeah, the non-judgmental part is, don't put a negative label on it and say, oh my God, I have anxiety, it's terrible, I'm a weak person. Most people don't have anxiety coming to this workshop, and most people can come and sit in here without freaking out, why am I so bad, Just saying, well, it's anxiety, I recognize my heart rate increasing, my muscles are tensing up a little bit. I mean, just call it what it is and be more objective about it.
Right. Okay.
Just practicing that. But I think the whole process really gets people in tune with paying attention to themselves.
Right.
And that's what I tend to focus on, is that attending to yourself so you know what's going on. And I'll bet that has the connection to the improvement in relapse.
Right.
Right. I mean, if you're attending to yourself, you might see earlier warning signs of what's going on and why, you're promoting your own depression through your negative thinking, perhaps.
Right. Yeah, and you also would probably be less likely to panic at the first sign of a symptom. I'm having this sadness again, okay? Doesn't necessarily mean I'm going back into a depression, I'm just having this. I don't know whether that's it or not, but there's something in it that is preventive of relapse, at least in adults, and it's worth, I think we ought to look at it in kids and see if it would be helpful too.
Well, and the clients really like it. I mean, at first it freaks them out because it's, you use these goofy kind of words, we talk about observe, but we're talking about, and they'll initially start like observing around the room and things like that, and observe, describe, participate, non-judgmental, one mindful, effectively, and it freaks them out a little bit. But then as they start practicing it, they really like it. Now that's adults, generally borderline adults, who are very much like adolescents, in a lot of ways, in the way they can't regulate emotion effectively and act out of emotion quite often, and are often precognitive initially, and so I think we teach them to be better examiners of their cognitions, and then they have better results.
Yeah, good. Yeah. Okay, thank you. That's a really good example of developments in the field that are more recent and very promising. And they can be, as it is done in DBT, they're kind of incorporated into sort of a CBT model. I mean, I know that Marsha Linehan, her book is called Cognitive Behavior Therapy for Borderline Personality Disorder. She gave a talk at our place a number of years ago and said, initially she really didn't want to call it that because she thought it was different, from CBT, but the publisher thought, well, it would be more attractive to people who could kind of integrate it with CBT and things they're already doing. So it can be integrated with CBT, and it often is. Okay, so I guess the last example I have of how you might try to, is it the last example? Okay. The last example I have is behavioral experiments, which would be where you ask the kid to do something particular during the week and notice how they feel and what thoughts they have about it. For example, you ask the teenager to call a friend on the telephone. That's their homework assignment. But also part of it is to notice how they feel while they're doing that and what thoughts they have about it, especially before they do it, okay? And one of the people that I worked with a couple of years ago had lots of people I work with have social anxiety, but one of the adolescents I worked with a few years ago had really very serious social anxiety that contributed to their depression. And so a homework assignment for him was to contact a friend just by email, not even make a telephone call, just contact them by email. And to notice how they felt when doing that, what thoughts they had when doing that, and then how they felt after they did it, okay? So now, this is a blend of treating depression and treating anxiety. This is really more treating anxiety, but he was able to notice that he did feel anxious even before sending an email, that after it was over, his anxiety dropped, and when he got a response from his friend, his anxiety was non-existent, okay? So that example is an example of a behavioral experiment that has two payoffs. One is that he became aware of his feeling and his thought. His thought was that, what will happen if they don't answer me? Kind of an anxious thought. And then the actual experience of, it's an exposure task. You heard about exposure in the talks on anxiety. That's an exposure task. You do the thing that you're afraid of, and you find out that it's not so bad, okay? So that's an example of a behavioral experiment. I already mentioned the daily thought record, event, thought, and emotion, okay? What about other here and now things?
One thing that I find difficult is, obviously, you know, if a child or adolescent is overgeneralizing and the distortions are extreme, so you can help them come down a little bit. But I think what's challenging is let's take the social, you know, the social anxious child or adolescent, and the truth is this child or adolescent, you know, possesses several social deficits, and it's being confirmed accurately in school. They're being bullied, and they really, it's true, they really have these deficits. So you can tell them, you know, automatic thoughts and cognitive distortions, but at the end of the day, it is true. You sense and you can see the social anxious child or somebody who has real social skill deficits.
Exactly.
And I find that to be, again, to an oftentimes they're to an extreme, and you can get them to come down a little bit. But I'm just curious how you circumvent, you know, cases where a lot of these problems are real. You know,
Good question.
They're not distortions.
Good question. So the question is, what do you do in cases where the cognitions are, at least in part, accurate and they're not distortions? So in the case that you mentioned, a child may have social anxiety and social skills deficits and negative peer interactions and be the victim of bullying. And so if they come in and they tell you something like, people don't like me, it's not just a cognitive distortion. It's not just a cognitive distortion. So how do we deal with this? Well, this is exactly why we put a lot of different skills in the manual, because we wanted people to be able to do social skills training if they thought there was a real social skills deficit, and to make a distinction between a distortion and an accurate perception of deficit. So now, I mean, I don't know how accurately therapists can do that, but I mean, I think they're pretty good at it. If we felt that a child needed to learn how to interact with people, we would go to one of the modules that I'll do this afternoon, which is the social interaction module, or the assertiveness module, something like that. At the same time, we made sure everybody had this cognitive restructuring because they were depressed, and we were assuming that some of the depression was due to the way they were interpreting things. Now, I talked with one of you yesterday about the circumstance of kids who are living in terrible environmental circumstances, impoverished families, no social resources. You know, their negative mood is a reflection of their reality to some extent. It's not a cognitive distortion. Still, you know, some people come out of that okay. And we want to help them be one of those people that comes out of it okay. And how do they come out of it okay? Well, they come out of it okay by a variety of means. I mean, some of them identify with some figure who has previously come out of a similar situation. You know, like a prominent athlete who comes from a very impoverished background. Or somebody in the news, or an actor or an actress, or somebody that is in the public who also had an impoverished or disadvantaged background. So they identify with them, and the identification helps them be hopeful. So one of the things, I know I'm going a little bit off from your question, which was more about social anxiety, but it reminded me of the question yesterday. One of the things that you have to do as a cognitive therapist if you work with depressed kids is you have to not give in to your own hopelessness. Beck talks about this in his book, in the 1979 book, A Cognitive Therapy of Depression. The challenge of working with depressed people is that they can suck you into the hopelessness. And so, I don't know if you've ever seen Beck in action. I had the privilege once of role-playing with him. He was training our group to do cognitive therapy, and I did a role play. I was an oppositional adolescent, which was not that hard to do. You know? And he was the therapist, and if you see him in action, he's relentless. Relentless, kind, and firm. And he just doesn't give in to the negative thinking. He's always kind of questioning it or asking if there's another way you can look at it. And I can see that in the book, you know, where you just don't surrender to the hopelessness. Now, you may need to go out after work with a buddy, you know, to kind of deal with this, or talk about it with colleagues, or get consultation. But that's the key thing, is not to collude in the hopelessness, even when the patient's situation seems hopeless. Okay? There's always got to be some way to look at it differently, and at least slightly more optimistically. So I try to do that in practice. I think it was really a powerful role play. It only went on for like 10 minutes, but you could see him in action doing this. And I guess if you ever see tapes of him or people in his group doing it, you can see the same thing. Okay. Here's the example that I talked about earlier. To teach kids that there's more than one way to think about events, you can use that traffic accident exercise that I talked about, where you're in a traffic accident, describe at least 2 feelings you could have, and then what are the thoughts connected with it. You can, if kids tell you that, you know, the way they think is just the way it is, and they'll never change, and they're totally right, you can ask them if they've ever changed their mind about anything. And common examples from childhood would be, you know, did you ever believe in Santa Claus? Did you change your mind about it? I mean, if they're still believing in Santa Claus when they're 15, you got another issue. But attitudes toward the opposite sex, if they can remember what they felt when they were little, and then do they still feel the same way? Music. Now this would be for older people, but you know, they change their taste in music, or they change their taste in anything. If you've ever changed your mind in your life, you're capable of changing your mind. Ronald Reagan is the great example, right? The Democrat president of the Screen Actors Guild, who became the prominent conservative. I mean, I'm sure there are lots of examples, but his is pretty, a lot of people know about it, so. Okay, now, once you have elicited the negative or depressive thoughts, you have to do something with them, okay? And so I want to spend a little bit of time on the methods of cognitive restructuring, okay? So step one is to elicit the automatic thoughts and the negative cognitions and the cognitive distortions, and step two is then to try to restructure them. So these are the classic Beck questions. There's 3 questions. These questions are in all the Beck books about depression, anxiety, substance abuse, everything. This is the kind of core element of cognitive therapy. Is that thought absolutely, completely true? What's the evidence? Is there any other way to look at it? All right, so let's practice this for a minute. Anybody willing to role play a depressed adolescent, and I'll try to demonstrate these methods? You know, all you need is one negative thought. So it won't be too complicated. Okay. What's your name? Eva. So Eva, let's say the situation would be that we're in like middle of the 12 weeks of the first 12 weeks of treatment, like week 6 or so, 5 or 6, somewhere in there. So I already have a pretty good sense of what Eva's negative cognitions are. And then we're going to try to do cognitive restructuring, okay? And I'm going to use at least one method and maybe 2, okay? So do you remember last week you took that triple column paper home that had events and feelings and thoughts? Did you get a chance to use that at all during the week?
Yeah, I did. And, well, okay, I have a friend, and she still doesn't want to talk to me, and she just doesn't like me, and I don't know what to do. And I feel very bad.
Tell me about this friend. Is this a friend for a long time, or a new friend, or who is the friend?
Yeah, my friend I've known for a long time, and she used to be my best friend, and now she has other friends, and she forgets all the things I did for her and how I stood by her and, you know, helped her when she was down, and she just doesn't want to know me.
So what does this mean to you, this problem you're having with this friend? And what's the effect it's having on you? What kind of impact is it having on you? How's it making you think?
It's making me think there's something wrong with me, and that maybe I'm a bad person, and that, you know, why would anybody want to be my friend?
Okay. All right, good. So let's just, for a minute, let's just work on those thoughts, okay? We can also, you know, do other things, but let's work on the thoughts for a minute. So the thought that you're a bad person or nobody will want to be your friend is a thought that's pretty, you know, sad, right? Now, if you think back on the last week, what's the evidence that that's true?
That shows I'm a bad friend?
Yeah.
Or a bad person?
Yeah.
Well, because when she didn't say anything to me, I thought in my head, what a jerk, you know, and she must hate me. And maybe I told her the truth one too many times or something. Maybe she didn't like what she heard, or maybe I shouldn't have said what I said.
What did you say?
Well, I told her that she was fat, and the reason she was fat is because she didn't have any other, you know, she just ate too much, and that was bad for her. And if she was going to keep going that way, nobody was going to like her, especially not boys.
And why did you tell her?
Because it's true. Because that's what I, you know, that's what I think.
Were you concerned about her when you told us?
Yeah, I was kind of concerned, but I was also kind of disgusted because she eats too much.
Not taking care of
Right, but she just, you know, she doesn't care, and she's looking worse and worse.
Okay, so I got a good sense of what kind of led up to the break between you and her. Now, the evidence, but what's the evidence that you're a bad person or nobody will like you? The only evidence I've heard so far is that she didn't talk to you when you tried to talk to her. Is there other evidence anywhere in the week that would tell you that you're a bad person or people won't like you? Anybody else give you any feedback like that?
Well, when I walked down the hall and there were some of her friends and some of my friends thought, hey, what a bitch, you know? Why are you telling her all this stuff? It's not nice, you know, you don't make friends that way. You know, why can't you just not say anything at all? Why do you have to tell her, you know, the brutal, honest truth? So I think I sort of saw other people kind of like looking funny at me when I said anything. It was like, oh, what else was she going to say that was going to be critical?
Okay, so another piece of evidence is that your own friends thought maybe you were too harsh on her, or, you know, something like mean? Okay, all right. So that's two pieces of evidence. Any other evidence that people won't like you or won't want to be your friend? Anything that came up during the week with friends or family or anybody else?
Yeah, well, my mom said, well, how do you expect to have her as a friend if you're always going to be putting her down? That made me think.
All right, so now let's look at the other side of it. So you got three pieces of evidence on the one side. Is there any evidence that people might like you or that you're a good person? Anything that happened during the week that would suggest that?
Well, in class, I had the right answer,
Okay.
and so people kind of looked like that.
They were impressed.
Yeah, they were impressed.
Okay, so that's one. Any other evidence that you're a good person or that people might like you?
Nah.
No other evidence at all?
Mm-mm.
Okay. How many other people are in your class besides this girl that you had in contact
20.
with? And how many of them are acting toward you like you're not a good person?
2 or 3,
2 or 3.
because I don't know the rest of the
You know,
kids.
so the rest of them are kind of neutral, they're not doing anything?
Yeah, they're not really people I associate with.
Okay.
They're just in the class.
But it's interesting that only a couple of people are really acting toward you like you're a bad person. You think that that's where they're at. Now, I want to add something different. I have to switch here because there's another thing that comes to mind. Is there any other way to look at this feedback you're getting from your mother and from your friends that's different from, I'm a bad person, nobody's going to want to be my friend? Is there any way you can look at that feedback?
Maybe that I don't know how to say the right things to people, or that I don't say the right things to people. I can't help it, though. That's the way I feel. That's, you know, I can't lie.
Okay, well, let's hold off on that for a minute. If they're telling you that maybe there's a way to be nicer to people, why would they bother telling you that? Why are they telling you that?
Because that's how people are supposed to be.
Why are they telling you that?
Because I'm not being what I'm supposed to be.
Okay. Why are they bothering to tell you? What's motivating?
Because they want me to act right.
Because?
Because it's the right thing to do.
All right. Now I'm going to have to come down here. It might be that they're telling you this because they care about you. Have you thought about that?
Well, if they cared about me, why would they criticize me?
Have you ever said anything critical to anybody that you cared about? Like maybe your friend who's fat? Right, it goes to a belief system. All right, so let's stop for a minute and get some feedback from the group about this. How would you go with this? I mean, there's a million ways you could go with it, right? Even within a CBT framework. How would you go with it?
I think you move it towards separating her as a person.
As you're moving toward separating her as a person, I'm a bad person, to maybe some bad behavior.
Yeah, right. Skills, kind of a skill test. Sort of like, I want to get to the point where she can see that these people are doing this because they care about her, and you know, and we have to help her get beyond the. This reminds me of a friend of mine from 8th grade. He was exactly like this. He went through this period where he just had to tell everybody everything he felt that was negative about them. And he got over it, you know, and he became actually, he ended up as a superintendent of schools in one of the counties. It's a true story. He kept doing it. All right, how else would you go with this? How else could you go with it?
I think when people are scared and care, they have a tendency to just, you know, I'm afraid that you're going to die, I'm afraid that you're going to get sick. So to make her look at the way she expressed it is not the best way, but she's just scared for her friend. She cares for her friend, so I will go that way.
So that would take it more in the emotional direction, like we talked about earlier with parents being scared about their kids, and that's why they set limits, okay? So that's another way you could go. You could go with the feeling. And that often moves things faster than staying with the cognition. It's a legitimate way to go in CBT.
She said something about feeling disgusted about the way she ate. So maybe we can explore those feelings. Was it more of her concern that she was becoming fat, or is the disgust? Because disgust would lead to perhaps being critical, but if you were more concerned about that person, then perhaps you would say the things in a different way. So if you can be really sure about what was motivating you to say that to her, what were your emotions, how did you feel when she was eating too much? So if you get connected to your own feeling of her behavior being generated in you, then perhaps your feedback to her behavior would be different.
So that is also an emotion-focused way to go with it. Okay, what is the feeling she's having toward her friend? Is it criticism? Is it disgust? Is it concern, or what? And then that might lead you then to other thoughts that could be restructured. Okay. Other ideas?
Maybe even asking her to give examples of other bad people and what they do and what makes them bad people, and then comparing how did this behavior compare to that, and then kind of going back to the emotion of if you care about other people, that's not a bad person quality.
Right. So that would be digging into the idea of bad. What does it mean to be bad? How are other people bad? How are you bad? Why are people bad? And, you know, you'd be looking for something good at the bottom of all that, right? Okay. Yeah.
Well, I was thinking that since she's pretty adamant about the importance of giving the information of what's wrong with these people, it might be good to pursue making choices and not necessarily letting all your helpful criticism hang out all the time. You know, you have to choose between whether you want this person as a friend or whether you want to give all this information to her.
Right. All right. So that leads to another, this is a thought I had when we were doing the role play. There are other modules you could use to deal with this besides cognitive restructuring. What's the module on choices? Problem solving. You could do a problem solving. You could handle this whole thing with problem solving. What's the goal you have? What's the problem? What are your alternatives? And what are the pros and cons? And I probably would get to that if this was, you know, a big thing interfering with her social life. and contributing to her depression. And I hear now her mother's also concerned about it, and the other kids are concerned about it. So kind of a combination of social skills and problem solving.
I just want to point out that I think also the benefit of using the language, is there any other way to look at it? I once went to one of Judith Beck's conferences, and she said you want to avoid at all costs using the word distortion, because you are implying that their thinking is distorted, and that's really not what you're saying. When you ask the question, is there another way to look at it, you're not discounting the way that they're looking at it. If anything, you might even want to validate that, I understand why you would look at the situation in this way, but is there another way? And oftentimes situations can be looked at from multiple perspectives. So.
And that may explain why the Beck people don't focus much on distortions anymore. They don't talk about it. David Burns did in that book, Feeling Good, and we did use that. We have this in the TADS manual. But the Beck Institute itself doesn't talk much about distortions anymore. Okay, any other thoughts about this? All right, well, thank you. That was really good.
I just want to say, I was trying to model one of my students that I was working with last year, who was kind of borderline social phobic and autistic. And he had this incredibly entrenched belief system. And, everything was bleak, everything was like, similar to this, but worse. Yeah. And I had a really hard time, trying all these different methods with him to make him see other alternatives, but he couldn't do it. And I don't know whether that was his autistic rigidity, that just didn't allow him to, even in conversation. But one thing that happened sort of aside from that was in the beginning, he would not talk to me very much at all. He was very inflexible. He would only give me one-word answers, to questions, and I had to, kind of open up my questioning to more open-ended questions because it wasn't working the other way. And eventually, sort of the side effect of what happened was that he started to get more argumentative with me, and he started to really express himself a little bit better. But he had these rigid, attitudes and beliefs that I'm finding with other people too. It's very hard to rip apart that belief system, even with all this question. I think you're trying to frustrate you.
Yeah, that was good. Yeah, that's realistic. So, you have to decide at some point whether you think this is worth it or not, or whether you want to go to some other approach. I have worked with some kids who have Asperger's and depression, and I found myself doing more and more of the behavioral activation. I just couldn't get anywhere with the cognitive restructuring. It was like there's not enough cognitive flexibility there to do it. And so there's an argument in the field about this. The argument is whether you should base your CBT on what they already do well, or you should base your CBT on their deficits. Greg Clark has written about this from his work with adolescents. And, on the whole, there's a good bit of evidence that people benefit from CBT because it builds on what they already do a little bit well. And that there's less evidence that they benefit from a really heavily deficit-focused approach. So that's why we want the positive skills to be part of the case formulation.
Just a resource.
Brooks at Harvard, I'm trying to remember the first name, all about islands of competence. You probably heard the term someplace. That's who invented it, I believe. And talking about trying to always identify, I'm always telling parents, you got to have your radar on high. Always be looking for the things they do well, and we build upon those, and if we build the island of competence, it pushes away a sea of troubles. Okay.
Thank you. Okay, thanks for that role play. That was really helpful. I was able to work in one thing that I find helpful sometimes with kids who feel like everybody doesn't like them, and that is to get an actual count of the people that are in their class or people in their social network, and to just kind of pin down, now, how many of these people actually are sure don't like you? And there will be some, but it's often enlightening to them to realize that most people are either neutral or somewhat positive. I had a girl in treatment years ago who had made a suicide attempt, and she had a very negative view of other people. What Beck would call the world, the social world. And we did this. She had negative views of teachers, classmates, family members. I think she wasn't too crazy about me half the time. And so we really worked on testing that belief. Look at all your teachers now. How many teachers do you have conflict with? And it turned out like 2 teachers out of 6 she had conflict with, and some of the others were quite supportive. Okay? So that's an example of what's the evidence. And you can then take this exercise and make a homework out of it. Like, go next week and look for evidence, pro and con, on this belief. Okay? So this is more on the example of peers. Nobody likes me. This was similar to what you were role-playing. You agree that this is a recurring thought. What peer behaviors support it? What peer behaviors don't support it? Select a group of people to use to test it out. What's the evidence? What teachers? What behavior? Okay. It's also helpful to use a grid like this, on which the person first identifies how strongly they hold the belief. So somewhere between 1% and 100%. Because you're giving them a meta message here that these things exist along a continuum. They're not absolutely, totally one way or the other. So if the belief is all of my teachers are jerks, you ask them, how much do you believe that? Then you get the evidence for it and against it. Then you formulate a new thought and say how much you believe the new thought. The new thought might be, some of my teachers are jerks, but some of them are fine. Okay? Okay, now the second one, which I did integrate into this exercise, was, is there any other way to look at it, which actually is my favorite. I like it more than testing for the evidence. And this is designed to increase cognitive flexibility. Remember, we said yesterday, problem solving is designed to increase flexibility. This is designed to increase cognitive flexibility. You come up with as many possible interpretations as possible that are realistic. So what happened? Well, in this instance of the role play that Eva was doing, what happened was that her friend stopped talking to her. And her thought was, nobody likes me, nobody wants to be my friend. And then we looked for other evidence, but it became pretty clear to me during the role play that there were other ways to look at these events. That the event with her mother, the event with a friend, and the event with her peers. And that could have led to a new thought, which it did in the role play. Although I had to sort of give her the thought at the end. I mean, I was torn between whether I should say what I really thought or whether I should wait for her to come up with it. Of course, ideally, it's best if the patient comes up with the thought, okay? But I don't think it's a mortal sin to give the person the thought if you think that it's pretty important and it might move them along a little bit, if they're at least partially the way along. And in fact, this is the difference between the Beck model and the Lewinson-Clark model. In the Lewinson and Clark model, they give kids lists of possible alternative thoughts and they just hand it to them and they say, are these some other ways you could look at it? So they make it easier for the kids to come up with a thought. Now, there are a lot of cognitive methods. We've only talked about 2 of them. What is the evidence and is there another way to look at it? Let's talk a little bit about these other alternatives. Let's talk about pro-con analysis for a moment. This is one that is often very useful with teenagers. but it's a little tricky, so you have to decide if you're going to use it or not. Pro-con analysis. Let's say that I have a kid in treatment who has the belief that, or the automatic thought that, he has the automatic thought that no girl will ever agree to go out with me. That's his automatic thought. What's the underlying belief? What's the core belief? I am unlovable. But we're not dealing with the core belief. We're just dealing with the automatic thought, okay? I could say to him, so you have this belief, and what are the disadvantages of having this belief? And I wonder if there are any advantages of it. Does it do anything for you? Is it a plus in any way to believe this? Exactly. I won't take a chance. I won't ask her out, so I'm protected from being foolish. I'm protected from success. I'm even protected from failure. I mean, I'm not going to take a chance. So there's a benefit to this belief. Now, of course, you're treating this kid for depression, so he's not likely to come in thinking that his negative thoughts have a benefit. So you're kind of hitting him from the other side of the fence. Okay, and that's why I call it a jarring intervention. It shakes up the belief system. David Brent likes to use this first for that reason. He thinks this is really a productive restructuring method with a lot of adolescents, because adolescents are so wedded to their thoughts and they're so convinced that the way they see things is the way it is, that if you go in first with, is there any other alternative, you might get no, okay? Or if you go looking for evidence, they might get into a debate with you about what the evidence means and so forth. So he likes to go in with this early and get them to hear from you the message that the way you think, is serving some function. And if there are other ways you can get that need met, you don't have to keep thinking like this. So it undercuts the adolescent's absolute belief in a thought. So if I think that the belief is serving some kind of a payoff, that's when I would be inclined to use this. What are the advantages and disadvantages of believing this? I'll never get a job. Well, I can see where a lot of people would have this belief right now. So, I mean, I wrote this slide a couple years ago. That's not necessarily, it's not a very helpful belief. I mean, you could still look at the pros and cons of it, but you'd have to be really careful not to criticize them for the economic problem. But if you truly believe that you'll never get a job, then you're certainly less motivated to look for one, okay? Here's one of our favorites, right? Everybody does drugs. I think it's been true that almost every adolescent I've ever seen for substance abuse thinks all adolescents are substance abusing. And in fact, it's part of the CBT for substance abuse to give them accurate information on rates of different behaviors, like, how many people actually do drink, or how many people use marijuana, and how many people use what other drugs at different ages. So obviously the advantage of believing that everybody does drugs is it gives me permission to do drugs, okay? What are the disadvantages of it? It undercuts my motivation to do anything about it, right? I mean, it's kind of a surrender. A common one with depressed people is, I will always feel this way, okay? What are the advantages and disadvantages of that belief? Well, the disadvantages are pretty obvious. It's a hopeless belief that leads you to feel bad. Are there any advantages to feeling this way, to thinking this way? Pardon? You kind of accept it, so you're not going to do anything about it, right? So it undercuts your motivation for treatment. You know, why would you bother taking a medicine, or why would you bother doing all this CBT stuff, which is kind of hard to do? It's behavioral, it takes time, it involves learning skills, it involves change. Why would you bother doing that if you think you're always going to be depressed? Okay? So you look at the pros and cons in terms of helping the person get motivated to change. That's really the reason for it. And you can use information in some of these cases. You know, there's a lot of information on how many high school students actually use drugs. And you know, it's true that a lot of high school students drink, and it's true that a substantial number use marijuana, but how often do they use it? And you know, there's very low numbers of hard drug use. You can use the Monitoring the Future study. You know, that's available online. And they update it every year out of the University of Michigan, and it gives you drug usage rates for the past 30 days or the past year for alcohol, marijuana, and other drugs. Okay. I made a point of this the other day that depression is an episodic disorder. The chances are extraordinarily high that you will feel better. I mean, I'd say the chances are above 90% that you will feel better. They're not 100%, but they're above 90% that you will feel better eventually. Okay. Okay, the next method, I know I'm going through these kind of quickly, but let me mention another book that you might want to look at. It's called Cognitive Therapy for Adolescent Depression by Wilkes, W-I-L-K-E-S. And it has all of these techniques in it, and it's got examples and transcripts of sessions, and it shows you, how to do them all in more detail than in the TADS manual, we just basically list them and briefly describe them, and we leave it up to the therapist which one they want to use. But if you want more detailed explanation of how they actually work, I would recommend the Wilkes book. It's a Guilford book. It's older now, but he did a study in Texas with adolescent depression using cognitive therapy and used some of the material out of the study to write the book. I think it's a very good book. So the next one is Downward Arrow. Now, usually this is for anxiety and for catastrophizing. So anxious people tend to catastrophize, right? I failed a test, therefore I'm going to fail the course, therefore I'm going to fail high school, therefore I'm going to never get to college, therefore I'll never get a job, therefore nobody will ever want to marry me, therefore I will never have children, therefore I will end up, alone in the gutter, okay? All because I failed a test. So the downward arrow is you have to do this with a bit of humor or a bit of a little twinkle in your eye or something, because what you're basically doing is pushing people to see how absurd their belief is. So you don't want to do it in a way that's derogatory or critical. But you just keep saying, it's basically a process of saying, well, what if that were true? Or as one of my colleagues used to say, so what? Okay? What if that were true? What would that mean? What's the worst thing that could happen? And your goal is to push it to the ridiculous. If I had wanted to get to core beliefs at that point, I could have said, well, what would it mean to you if somebody didn't like you? Well, it would mean a lot of people would not want to be with me, and I'd be lonely, and then I could say, and what would that mean? And I'd try to keep pushing her down to the core belief that would mean I'm just not a very lovable person. Now, here's a big issue in the field for adult and child. Do you need to get to the core belief? Judith Beck would say yes, right? Would she? Do you think, from taking the workshop? I think so, yeah. And they try to get to it faster than they used to. When David Brent did his 97 study, he wrote in the manual, in the manual for CBT, you will not be likely to get to core beliefs in a 12 to 16 week treatment. That was because he had studied at the Beck Institute in, 1990 or something. At the Beck Institute now, they try to get to the core belief faster, and thinking that that is essential to the treatment. So that's one side of the argument. The other side of the argument is evidence from some adult and some adolescent studies that people seem to improve even if they never get to the core belief in the treatment. That if the treatment only changes the automatic thoughts, but gives the person the potential, the ability to cognitively restructure, that seems to carry the weight. Okay? So I don't know, what the answer is to this. We did not push therapists to get to the core beliefs because we were kind of following the Brent model. And I don't know how many of them got to core beliefs. I know that Kevin Stark, who trained more recently at the Beck Institute and works with depressed kids, also tries to get to the core beliefs. And he also tries to restructure the core beliefs using additional methods, which we could talk about after lunch if you want. But this is a way to get to the core belief. Okay, you push it, the downward arrow from the automatic thought down to what's the underlying belief. Okay. Okay. Another method is responsibility reattribution. And this is for kids where the depression is accompanied by a lot of guilt. Now, in my experience with adolescents, this is not a real common part of the depression, but it does happen in some cases. Or it happens in other diagnostic groups where kids feel guilty for things for which they are really not responsible. I mean, it's kind of a classic issue in child psychology that children of highly conflicted parents often feel guilty about it. If their parents divorce, they feel guilty about it. Or you can have survivor guilt. Why did I survive that automobile accident and my friend was killed? I've seen kids in that situation. So when you feel like there is excessive personal responsibility or excessive guilt, you can use this pie chart idea. Now, I have strong feelings about guilt. I think it's because my first job was in juvenile court. I really liked guilt. We were always looking for it. Any sign of guilt was a good thing in juvenile court, So I don't want to discount guilt entirely. I don't want to say to somebody, you shouldn't feel guilty, it's not your fault. I think that's totally useless. And I guess this isn't really different than any other emotion. You don't want to discount the person's emotion that they present to you in the session. So if a kid comes in and they have been in an automobile accident and maybe they were the driver and somebody died in the automobile accident and they feel terribly guilty about this, the last thing I would say to them is, you shouldn't feel guilty about that. That's like saying you shouldn't feel happy, you shouldn't feel depressed, you shouldn't, that's what. So the pie chart idea is, let's look at the whole picture of this accident and everything that contributed to it, and let's see if there were other people or other factors that also contributed to it. And we'll consider that whole bundle of responsibility to be a pie. And then we'll divide up the pie in a chart, and we'll figure out how much, if any, of the guilt does belong to you, and how much of it belongs to other people, or just bad luck, or chance, okay? So it's a way to kind of mitigate the guilt, or get it back to a more realistic level. Could you speak into the mic? I'm just trying to get everything on the tape.
I was interested in basically shame and its
shame and guilt, yeah.
relationship with depression. So I came across some recent work, in which they differentiate not only guilt from depression, but also specify the kind of guilt that is associated with depression and the kind of guilt that is helpful
Yeah.
the way you were saying.
Yeah.
So the guilt, which is specific about the behavior, is
Right.
something desirable.
Right.
Guilt that is very generalized and takes the whole self, that is something that we don't
That's right.
do.
That's
so that's
right.
not healthy.
That's right.
That's what I want to say.
And some, like June Tangney at George Mason, she talks about guilt and shame in this way. So shame is when you feel totally pervasively negative about yourself because of some event, whereas guilt is, okay, I did this thing that wasn't good, okay? So if I tell a lie, you know, I should feel guilty about that, but that doesn't mean that I am a totally worthless, useless, you know, whatever, which would be what she calls shame. And so I think that's very helpful, and that's a good way to make the distinction. So we do want people to not get into pervasive shame, but taking responsibility that's acceptable for, you know, what they actually did would be consistent with this pie chart approach. Okay? And you can get, I mean, I don't want to minimize the fact that you can get depressed people who have terrible guilt and even psychotic guilt, you know, where they feel like they're responsible for something they are utterly not responsible for. And you can get that in survivor guilt, you know, where the person's totally not responsible for a hurricane or a fire, but because they survived it and somebody else didn't, they have this terrible feeling of guilt. There's really no responsibility, okay?